Good afternoon. At the outset, I'd like to thank Dr. Nitin Balakrishnan for giving me this opportunity. I hope I'm audible. So my topic is on fighting the bulge with INTACS and CAIRS. INTACS I've been doing for the past 14 years with excellent results, and recently we started using CAIRS. So I'm going to share my experience. So the indications are patients who have inadequate vision with spectacles, intolerance to contact lens wear, patients with keratometric readings of greater than 52 diopters, stage 2 to 3 keratoconus based on amsalochromic classification, patients with clear central corneas, and cylinder of at least 4 to 4.5 diopters. So case 1 is a patient who is a 21-year-old male who had a corrected vision of 6.9 with 3.75 CIL. You can see on the topography, you can see the cylindrical error is about 5.93. So this is the pre-op pentacam. Pentacam also show a 4-cylinder, and almost all the parameters are in red. This is an AIOC just to make sure that there is no thickening of the epithelium. So this is a plan. So this plan, I have to thank Dr. Susan Jacob for giving me this plan. So this is what she has planned. She had planned was it's 4.6 to 7.1 millimeter. This is a zone that we are going to place the CAIRS segment. And the trifine size is 6.5 to 8 millimeters, a position between 4.5 to 8.5. And normally the depth of the cornea is half cornea plus 50 microns. So this was, in this case, was 300 microns. And the incision site was normally is around 180. You can plan, the incision is really dependent on how comfortable you are with inserting the segment, and you can plan at any area. So this is how the plan looks. And this is literally my first case, and I'm using a femtosecond laser from Alcon, but no financial interest. And after making the channels, you can use that wise spatula to just open out the channel a little bit. I like to mark the area where I'm going to put the segments, and the segment has been already prepared, and it's inserted into the area where I want the segments to go. You can make an alternative opening in the other area where you want this if you want to pull it out. If you're not able to insert, in case of long segments, I'd like to make another opening here so that I can use a Sinskey hook to pull it out. But in this case, it was a slightly short segment, and we completed the case without using another opening. So this patient dropped cylinder from -3.5 to +1, and his uncorrected visual acuity improved to 612. And you can see the flattening is about 3.5 to 3.8. Most often we see that the spectacle cylinder may not coincide exactly with what you see on topography, but it's a comfort of the patient. The patient feels a lot more comfortable with uncorrected visual acuity. So this is a 1-month post-op of the same patient. And this is the pre-op, the comparison map at the end of 1 month. You can see a significant flattening. You can see the comparison map showing the amount of correction. At the end of 3 months, you can see a significantly more correction because we have added cross-linking as well, and the significant more flattening also is seen. And this is the AIOC as well as slit lamp photo showing the CAIRS segment. And this is the Hoya trace refraction. I wanted the eye trace refraction. And the eye trace shows only a 1.62 cylinder, though the actual acceptance was a little bit more. And this is a 3-month post-op. Topographically, you can see there is a reduction from 5.93 to 4, but the patient accepted only about 1.25 CIL. So this is again a power difference map showing only a 1.5 diopters of induced reduction, but the patient's comfort and the increase in the best corrected visual acuity as well as the spectacle cylinder also significantly showed a change. So case 2 is a 17-year-old male who had a 5-cylinder. Again, you can see the plan, what we have done. So we are going to insert the cone in the area of the segment in the area of the steepest area of the cone. And this is the pre-op and the post-op, and you can see the significant flattening, and the post-op showing a drop from -5 to -1.5 CIL. So CAIRS works in 2 ways. It works as a volume replacement because the area of the cone is much thinner, and it sort of has a buttress on the area of the cone, so thereby preventing any further bulging of the cone. Also has an arc shortening effect which is similar to INTACS. The results are variable because there are no proper nomograms, no major side effects, because we see quite a lot of side effects over a period of time in INTACS. But however, whatever procedure we do, it has to be combined with CXL. So coming to INTACS, INTACS are crescent-shaped PMMA rings which are inserted to the corneal stroma. Normally they are placed at 70% depth, and you can see that it has an arc shortening effect. So this is the normal cornea, and after INTACS you can see the amount of flattening it produces. The deeper you go, the more the flattening, and the thicker the segment you use, again the more the flattening. So in case of INTACS, you need to have a pre-surgical planning. So in addition to UCVA, BCVA, corneal topography, corneal pachymetry, we also need to know the pachymetry at the different locations, especially in the location where we're going to insert the INTACS ring. So this is a small video which shows how the INTACS is being done. It's not playing. Okay. So this is a patient who had a minus 4.5 with minus 7.5 SIL. So the total mean spherical equivalent is around minus 12. So here in INTACS, you have to identify where you're going to make the incision. So you convert the minus 7.5 cylinder into a plus cylinder component. So you will get plus 12 with minus 12 with plus 7.5 cylinder at 115 degrees. So here at 125 degrees. So here we made an incision at 130 degrees looking at the posterior float as well. And we placed two segments because the mean spherical equivalent was higher. We placed a 0.5 SK segment superiorly as well as inferiorly. And this is a post-op showing an excellent response. You can see from minus 4.5 with minus 7.5, the patient dropped to minus 1 with 4.5. And it's almost half the mean spherical equivalent. This is again another patient who had a minus 2.25 with minus 4 SIL. And the planning here was using asymmetric segments. You can use a thinner segment, or you can just put a single segment, especially if you have a very inferior cone. The incision is again on the steeper cylinder, steeper axis. It's marked at 130 degrees. And in this case, the mean spherical equivalent was only about 6.25, so we used only a single segment. So this is a pre-op, and this is a post-op. You can see a significant reduction. In some patients, they do extremely well, and you can see that it's almost like a patient is able to see 6/9 even without glasses. So these are some of the other patients who had very good results. You can see the drop in cylinder, significant drop in cylinder. So we did a very small study when we started about 10 years back, and we found that the average reduction in cylinder post-INTACS was about 3.75. Some of them showing much more significant reduction of even up to 7 or 8 diopters. Some of them showing very little response. So the advantage or comparison between INTACS and CAIRS is INTACS is a very standardized procedure. We can plan, there are nomograms. They are more rigid, but they're a little bit expensive, and results are more predictable in INTACS, at least in my hands. In CAIRS, I think it still needs a little bit of fine-tuning. There are no nomograms. I've discussed with a lot of surgeons. Each of them do it in a different way, and each of them have their own optical zone. Some of them go very close to the center. Some of them go very far away. So there is no obvious nomogram. The only advantage is it's not expensive. The again important thing is it's a volume bidding procedure, and it's less rigid, more chance of tissue integration, tissue remodeling based on the endothelial pump and additional effect, and results are variable. Thank you. So I'd like to take the opportunity to announce the release of my color atlas today in Hall 1 at 6 o'clock along with the Specialties Award. I request all of you to please be there. Thank you.
How much axis of the posterior corneal curvature has effect on the choosing of the incision site?
How much is the axis, the posterior corneal curvature, does it influence your incision site? Yeah.
No, in INTACS. Not in CAIRS.
Excuse me.
Your screen is stretched. You need to make it. It's coming properly here. Anyway. After listening to, you have a question?
I have a question, Dr. Mohan.
Yeah, Dr. Ayush has a question for Dr. Sujatha. There is a question.
See, there's a lot of noise that TREC is replacing the INTACS and CAIRS. What is your view on it? Between TREC and the CAIRS and INTACS, a lot of noise that this is slowly replacing that.
I personally feel, yes sir, we have adequate nomograms. CAIRS will definitely be a better procedure because we don't have any complications, intrusion, extrusion, and patient rubbing his eyes really doesn't bother. And also there is some amount of increase in the volume of the cornea. So it should replace, but the only downside is that we really don't know the effect. We cannot promise the patient something and then come with the results. Whereas INTACS, I'm more confident. I know that at least 50% of the his mean spherical equivalent will go down, which I cannot promise with CAIRS. I think there are people like Rajesh Fogla is doing quite a lot of CAIRS. I think you should also give his opinion.